there are certain advantages of being short. The onconephrology is an upcoming field within the nephrology field where the nephrologist is focused on a patient with cancer who has kidney disease or has the kidneys have been affected either by the cancer or its treatment. Could be renal failure, could be electrolyte imbalance, or could be hypertension. And so the niche that it provides, I think, is really good at multiple levels that I'll discuss. So let me get started with what is the buzz. The buzz is so palpable. I did a Google search yesterday, and I came with more than 80,000 hits on this term. The renal textbook has devoted a chapter to renal disease in cancer patients. The Italian Societies of Nephrology and Oncology has proposed guidelines in management of CKD patients with cancer. The ASN has also have a scientific session now and Onconephrology Forum online. There is an onconephrology clinic now in the USA that really focuses only on patients with cancer, especially in the universities setting. And in the last couple of years, there have been fellowship in onconephrology at renowned cancer institutions in USA. Let me go over some of the epidemiology of kidney disease and cancer. I'll go over the epidemiology in the world, and then I'll focus, and then I'll get into the into the Indian epidemiology, where there is some paucity of data. So there is a decline in cancer death in the U.S. since 1990s, about 1.5% per year. It's more dramatic, though, in patients with lung, prostate, and colon cancer. It's about 3% per year. We are treating in the U.S. much older patients with cancer. They have a lot more comorbid conditions. They are given riskier chemotherapies. And the number of patients who are undergoing hematopoietic stem cell transplant has increased. So just to give you a perspective, it used to be 5% in 1990s. Now it's about 1/3 of those patients are about 50 years of age. The incidence of AKI is also documented well in the Danish population. As you know, Denmark has a really robust epidemiologics database, and they were able to find 37,000 patients who had cancer and also had a baseline creatinine. And they found that there was a significant burden of cumulative incidence of AKI at 1 year and at 5 years. So if you look at the rifle classification, it goes anywhere from just risk to renal failure. The incidence has been anywhere from 17% to all the way to 27%. Is there any link with type of cancer and AKI? And yes, there is. As we can imagine, renal cell carcinoma is an obvious. Multiple myeloma is an obvious too. But liver cancer has surfaced also as a cause of AKI. We know that lymphoma leukemia patients are subjected to a number of challenging chemotherapies, and their incidence of AKI is higher as well. And their morbidity and mortality is high if they develop AKI or if they are receiving renal replacement therapies. Hematopoietic cell transplantation, again, those patients are at higher risk for AKI, and we have to be aggressive in monitoring those patients. Patients with cancer are also at risk for CKD. About 16% had stage 3 or higher stage of CKD, and they required significant dose adjustment, up to more than 50% of patients in one cohort in France. A study from Taiwan actually showed that there is an adverse cancer-specific mortality that is inversely related to renal function, which means the lower your renal function, the higher the risk of mortality from cancer. We're not sure why that is the case, but certainly this is a tantalizing and intriguing finding. We also know that the hematopoietic cell transplant patients are at higher risk for CKD as well, not just AKI. They have a lower GFR, and they also have a significant decline in eGFR over a period of time. Multiple myeloma is not a surprise to any one of us with AKI and CKD, but also they require 1 out of 10 would require renal replacement therapy. Is there any link between the risk of cancer in patients with CKD? So it's the other way around. Patients who have CKD, are they at higher risk for cancer? And the answer, at least from the epidemiological evidence, suggests that yes. With every 10 ml per minute decrement in EGFR, there is an increase in cancer risk by 30%. This particular study, again, a French study, a different cohort, but a large French study of 5,000 odd patients, showed that patients with lung cancer and urinary tract cancers were the risk factors. We're not sure why gender is surfaced in this particular study, but it's likely a differential confounding, which means, there is an underlying risk in men, especially if they are an occupational hazard, that they are exposed to certain toxins that might be causing this particular phenomena. Patients with cancer also have, ESRD. We know that the patients with ESRD can have are at higher risk for cancer, especially with renal cell carcinoma, bladder, thyroid, other endocrine tumors. There is also a particular interesting finding where there is a risk of renal cell carcinoma that increases with time on dialysis. And the thought is that, the patients on dialysis do acquire cystic disease, and that may be one of the predisposing factor for those patients developing RCC. Patients with hematopoietic cell transplants also develop ESRD, and there are 16-fold higher risk of developing ESRD. The higher mortality even compared to ESRD with diabetes, as we know, is the highest risk for death and cardiovascular complication. The silver lining to the patients who underwent hematopoietic cell transplant is that if they develop ESRD, they can get the renal allograft from the same donor without subjecting them to the immunosuppressive treatment. In India, there have been expert opinions published in Lancet Oncology a couple of years ago that shows that there is a higher burden of cancer in India. Medscape also came up with similar article a couple of years ago as well. And the Times of India also published this, stating that there will be 5-fold increase in cancer incidence by 2025. This is not in too distant a future, I would say. But these are all expert opinions. The typical cancers that we would expect would be head and neck cancers in India, lung, upper GI, and GYN. So this is a little bit different than what we see in US and UK. There is a huge study that is ongoing. In fact, it just got completed, the Million Death Study, that is with collaboration of Registrar General of India, that has followed 14 million people in 2.4 million households over a 16-year period. And they came out with their initial finding that was published 2 years ago in Lancet that showed that up to 500,000 patients die every year from cancer in India. Again, this is a nationally representative sample. It's likely an underrepresentation of the true burden or true incident of death from cancer. But certainly now we have some number that we can quote. Of course, this does not get into the huge part of morbidity associated with cancer. There are also renal involvement, as we are aware of, with membranous nephropathy, as we all know, with solid tumors, minimal change disease. Again, HCT is a big risk factor for that can develop, that can cause nephrotic syndrome. And tumor lysis syndrome also we are well aware of, that is one of the complication that causes renal failure. Myeloma is a well-known disease that affects the kidneys. In fact, for some reason in USA, for the last few years, the USRDS database shows that the incidence of myeloma affecting kidneys requiring renal replacement therapy has plateaued. We are not sure why that is the case. It could be from the newer treatment that has been out there, the proteasome inhibitor, that may have helped reduce that, but that's a speculation. Amyloid-related kidney disease and light chain deposition disease are again a well-known finding where the kidneys get affected by these diseases. In the transplant centers where they are given conditional regimen, the hematopoietic cell transplant centers, there are few, but when they are given this, there is a special entity called veno-occlusive disease that occurs. And this occurs around the time of conditioning regimen. When they are given extensive chemotherapy, including cyclophosphamide, the liver has endothelial dysfunction in the hepatic sinusoid, and they develop hepatorenal physiology with painful hepatomegaly, edema, ascites, hyperbilirubinemia, and AKI. And the treatment for that is heparin and a newer FDA-approved drug called defibrotide, which is an anti-fibrinolytic, my apologies, a fibrinolytic as well as anti-thrombotic agent. And it has shown to reduce risk of renal replacement therapy in this patient population. There are also, as we know, that the renal involvement is also present with in patients who have cancer, and there is a macro level, meaning we would have an obvious finding on the CAT scan with involvement of kidney. This particular patient had flank pain with masses in the kidney. On biopsy, it was squamous cell carcinoma. It could also be on a microscopic level with lymphoma, as we know, it's lymphomatous infiltration. But unusual cases also are reported that we reported a few years ago in AJKD. It's a lysosomal induced AKI in patients with CMML. CMML is an entity which produces significant number of lysosomes, and that gets it's a cytotoxic. It's a very toxic molecule, and it causes AKI in these patients. And the treatment is giving prednisone. The more exciting part is anti-angiogenic therapy, which is a targeted therapy that we are now increasingly using in this in cancer. So vascular endothelial growth factor, or VEGF it is called, is a key element in progression of tumors, as we have come up to learn over the last couple of decades. In response to that, people have developed VEGF sequesters, VEGF receptor blockers, and in fact multiple target called tyrosine kinase inhibitors that not just blocks the VEGF, but also c-KIT and platelet-derived growth factors. And as you can see, there have been expanding indication for some of the drugs that may be familiar with you, for you, like Avastin, sunitinib, sorafenib, and these are the agents that are increasingly used as either first line or subsequent lines in patients with renal cell carcinoma, colorectal cancer, for non-small cell lung cancer, glioblastoma, as well as patients with ovarian cancer. And so the list keeps on expanding, and we have to be mindful because we would see them no matter what specialty we are in. A preeclampsia-like syndrome was reported by our group. I was the lead author, and this study has been now quoted for more than 100 times because it's a unique way of presenting the toxicity of these agents. It does behave like preeclampsia, where you would have proteinuria, hypertension, and edema, and even the physiology would be similar because in preeclampsia, as you know, the VEGF is also lower, but there is an element called SFLT1, which is the driving force in preeclampsia. In this case, it's the molecule or the drug that is driving the VEGF low. The anti-angiogenic therapy also has a higher risk for hypertension, with more than 90% causing blood pressure by day 6. And the hypertension has occurred in 1/4 of patients. So again, we have to be very mindful of these patients who are subjected to these agents. There's an increase in severity of hypertension in patients who have pre-existing hypertension. And the graph shows that once they are subjected to the agent, the blood pressure goes up. Once it's stopped, it comes down, and when it's reintroduced, it comes back up. Again, it proves the Cox hypothesis that we all know of. What are the mechanisms? The mechanisms proposed are decrease in nitric oxide, increase in endothelin 1, as well as capillary rarefaction, which means there are capillaries that are reduced over a period of time when there is a punch biopsy in the skin. But that takes time, and we don't think it's the primary driving factor for the hypertension. The management has been with calcium channel blocker, ACE inhibitor, or ARB. And then we have to be creative, right? Because we don't want to completely stop these agents. They may be life-saving. So we may have to either reduce or give prolonged drug holidays to reduce the toxicity on the kidneys. Our group also proposed the mechanism could be from paracrine or autocrine homeostasis disruption by these agents, because we know the podocyte is the driving force for this particular, for VEGF, and if VEGF is blocked by these agents, it could be detrimental effect on the kidneys. The glomerular findings that we see on the biopsy are to do with TTP. Sorry, my apologies, thrombotic microangiopathy, which is, again, a recurring finding that we have seen in preeclampsia patients as well. The electrolyte imbalance that we see in cancer are all well known with hyponatremia, hypercalcemia, but also hypomagnesemia is a well-known complication for cisplatin. A newer drug called cetuximab, which is an epidermal growth factor inhibitor, has been linked and in fact causes significant hypomagnesemia up to 90% of patients. Hypokalemia is also a known finding, a known complication of some of the agents as well as the tumors that we come across. So the span of onconephrology is quite broad, as you can see, from tumor-associated renal injury to tumor-associated electrolyte imbalance to tumor toxicity, renal toxicity of chemotherapeutic agents that I just went over. But also those patients are again subjected to the same things that we would be subjecting non-cancer patients, such as ACE, ARB. They may be on antibiotics. So these patients are also exposed to non-chemotherapeutic agents as well. And final thing is, as a nephrologist, we have to be mindful of the renal function and dose adjustment that they would need. I still think that we would need, the hemato-oncology person should be the key person who should run the show. But I firmly believe that the onconephrology would give a huge benefit to the team that is taking care of the patient, along with the rest of the team that are involved in the patient care. For India, it's ESRD for many patients is almost like a death sentence, because unless you get a renal transplant in timely manner, your chances of survival gets low, especially people who don't have resources. So you could, what I call it is you'll win a battle, but then you will lose a war. In this case, you'll win a battle by conquering the cancer, but you lose a war because now the patient is ESRD and the patient cannot survive anymore. Final thoughts are that, it humbles us because it gives us a pause that we know so little about the biology of human beings. We thought these are targeted therapies, but it turns out that they have other things that we didn't know about that affected some other organs. Again, it's an opportunity for nephrology field where we can have a niche and collaborate with our oncology colleagues as well as the radiation oncology and also surgical specialties. And I think, though the data is not there, I think it's really the right thing to do for patient care, because the sooner we detect patients with kidney disease or kidney toxicity associated with these agents, I think better off everybody would be.